This CE has been approved by the Alabama State Board of Pharmacy for the 2-hour mandated live CE renewal of Pharmacist Parenteral Recertification. In addition to this presentation, you'll be required to have a passing score on the quiz that will be emailed to you. It's important to remember that the CE is not ACPE accredited, and if audited by the Alabama State Board of Pharmacy, you'll be required to present a certificate of completion that I will provide after your successful completion. Also, to ensure full compliance with this program, you'll need to ensure that successful completion of fingertip and media fill sampling are on file at your facility. The learning objectives for the CE is to understand how the facility build contributes to the cleanliness of the controlled environments, distinguish between compounding categories and assign appropriate beyond use dating, describe the basics of cleaning and disinfection of controlled environments, know how to introduce components into the controlled environment, explain proper garbing and hand hygiene, explain the different elements of the garbing process for sterile hazardous drug compounding, describe the unique requirement for sterile compounding of hazardous drugs, identify critical sites, and successfully demonstrate aseptic technique. This slide contains acronyms and synonyms that you may see throughout this presentation and can be referred back to as needed. So what is considered sterile compounding? Sterile compounding includes the process of combining, admixing, diluting, pooling, reconstituting, or altering drug or bulk drug substances to make another drug. It's important to recognize also that repackaging is now included as sterile compounding. This was absent in the version 2008, but is now addressed in 2023 and is considered sterile compounding because we have to be as concerned with the sterility of the product when repackaging. So what is out of scope and not considered compounding? Well, if we follow the package insert of a manufacturer and it's for a single dose and for one patient, then this is not considered compounding. But there's a few things we must remember. Again, it has to be for a single patient and a single dose. Also, the package insert must include the diluent to be used, the resultant concentration, the container closure system to be used, as well as storage conditions. If these do not exist in the package insert, then this does not apply and it would be considered compounding. Also, proprietary vial and bag systems, if docking and activating for immediate use and for one patient, this is also not considered compounding. But again, the key here is it's for immediate use and for one patient only. If docking for future activation, this must occur in an ISO 5 PEC and is considered compounding. However, when assigning a beyond use date, the package insert by the manufacturer can be referred to for that assignment of the beyond use date. But it's really important to remember that the manufacturer cannot assess the sterility of a compound. They're looking at the stability. So it's advisable not to assign a beyond use date beyond USP 797 when assigning these type of beyond use dates. Now that we understand what is included in sterile compounding, we want to talk about our classified areas. These are our primary and our secondary engineering controls. The primary engineering control is known as your hoods or your PECs. The secondary engineering controls are the rooms in which we're compounding, or our SECs. We have to get these certified every 6 months, and it includes many different things, but we're not going to go over that in this presentation. But what we do want to concentrate on is what is called ISO classification. ISO classification is the determination of the cleanliness of the room in respects to the amount and the size of particles suspended in the air. It really has nothing to do with the microbial growth in the air at this point, but it has all to do with the number and the size of particles suspended in the air. Now, with saying that, it is true that with increased number of particles and increased size of particles, you do get more microbial growth in your air because microbial growth adhere to those particles and therefore increase in number. But really, again, ISO classification is only about the size and the number of particles suspended in the air. However, in our engineering controls, the primary and the secondary engineering controls, we have HEPA filters. These HEPA filters remove particles of 0.3 microns or larger to help us establish ISO classification. The chart below shows different ISO classifications and the number of particles that are required to meet that ISO classification. It doesn't have to be remembered or memorized for this presentation, but is there for your knowledge. Now that we understand more about ISO classification, let's move on and talk about categories and beyond use dating in USP 797 version 2023. In the older version 2008 USP 797, they focus on a risk-associated compounding, where they establish high, medium, and low risks, where they focus on the number of manipulation and the number of products being used, as well as if sterile or non-sterile ingredients are being used in order to associate risk back to that compounding process. However, now in 2023, USP 797, we see a shift. We now establish what is called Category 1, 2, and 3 compounding. Here, we focus on training and getting the process right. Now, Category 1, 2, and 3 is established by the environment and conditions under which the CSP or the final preparation is compounded. They look at the quality of garb, the cleaning, environmental monitoring, and sterilization or sterility testing done on the final preparation to determine what type of category and beyond use date will be assigned to the product. Category 1 compounding is done in a segregated compounding area or an SCA. This is a situation where you have an unclassified area or space. It can be a room or it can be just a visible parameter within another room. It has to be a defined area, a visible parameter, and dedicated only to compounding. This again is a situation where you have an ISO 5 PEC or a hood where you do the compounding inside this parameter. This parameter must be away from all other areas and also is limited to Category 1 beyond use dating, which is 12 hours at room temperature or 24 hours under refrigeration. There must be a sink used for hand hygiene, and it has to be located either inside or outside of the parameter, and it must be at least 1 meter away from the ISO 5 PEC. Category 1 compounding is done inside of a PEC that's located inside of a segregated compounding area, which again is an area that is unclassified. It could be an area or room that's unclassified. This will give you a beyond use dating of 12 hours at room temperature or 24 hours under refrigeration. As opposed to the older USP where it set limitations on segregated compounding areas, there's no longer any limitations to the amount of products or the number of entries you make into a container for Category 1. It is important to understand that a RABS, or what's known as a glove box, must be located in a full cleanroom suite to get longer beyond use dates. If a RABS is placed inside of a segregated compounding area, you must only give 12 hours at room temperature or 24 hours under refrigeration. Category 2 and Category 3 compounding is done in a full cleanroom suite. This means that you have an ISO 7 buffer room that's attached to an ISO 7 or an ISO 8 anteroom. HEPA filters will be located in the ceiling, and air returns will be located low on the wall. Although HEPA filters are required to be in the ceiling, air returns can be in other places, but if not low on the wall, then a special smoke study must be done to ensure proper airflow. Pressure differentials will be 0.020 greater than the surrounding area. This means that the ISO 7 buffer room will be 0.020 greater than the anteroom, and the anteroom will be positive 0.020 greater than the general pharmacy. Note that we're bringing this out to 3 decimal points, a positive 0.020 or greater. This is because we don't want to round up into compliance. A sink will be located on the inside or the outside of the anteroom and can be located on the dirty side or the clean side of the anteroom. There will also be a line of demarcation in the anteroom associated with garbing, and hand hygiene. Also, air changes per hour will have to meet the minimum requirements. For an ISO 7 room, the minimum requirement would be air changes per hour of greater to or equal to 30, with at least 15 air changes per hour coming from the HVAC. For an ISO 8 room, the air changes per hour must be equal to or greater than 20 air changes per hour. Category 2 compounding can be assigned various beyond use dates. It depends on whether or not you aseptically process the compound or if you terminally sterilize it, whether or not non-sterile components are being used or if only sterile components are being used, or what type of testing is done on the products, whether you're doing sterility testing or endotoxin testing. This slide shows the beyond use date in yellow that most Category 2 hospital pharmacies will be assigning. The reason for this is because we usually only aseptically process only sterile ingredients, and we don't really do any kind of sterility testing or bacterial endotoxin testing. Therefore, we'll be able to assign a beyond use date of 4 days at room temperature, 10 days under refrigeration, and 45 days frozen. Category 3 compounding is also done in a full cleanroom suite. However, we approach more of a CGMP type process, where only sterile garb is used, no exposed skin is allowed in the buffer room, and there's increased personnel training, increased environmental monitoring, and increased cleaning. We also look to see if something is being aseptically processed or if it's being terminally sterilized. We also want to see if we are using any non-sterile components or if only sterile components are being used, and what type of testing is being done on our final CSP. All this will help determine what type of beyond use date may be assigned to a Category 3 compound. Of special note, sterility testing is always mandated for Category 3 compounds. Endotoxin testing is only mandated if non-sterile components are being used. And also, every Category 3 compound must be backed by a stability study that references a stability indicating analytical method. An important note on assigning beyond use dates: they must be done conservatively. We also want to make sure we can find literature that supports the beyond use date we assign for Category 1-2 compounds. We want to ensure that the final preparation is physically and chemically compatible with the fluid, the container, the final CSP concentration, and the storage conditions under which we're keeping it. Now, for Category 3 compounds, we have to remember that this is an extreme requirement. Literature must be there to support the beyond use date of a Category 3 compound, and it must have a stability indicating analytical method referenced in that stability study. There's special consideration for non-preserved ophthalmics. First of all, they must be prepared in a Category 2 or Category 3 compounding area, and they can only be prepared for one patient and one patient only. Now, after they're compounded, they can be assigned a beyond use date according to the category under which they're compounded, which would be Category 2 or Category 3. However, once they're opened and started to be used, after 24 hours, they must be discarded if they're stored at room temperature, and 72 hours if they're stored under refrigeration. We can't conclude our discussion on beyond use dating without talking about immediate use compounding. Immediate use compounding may receive a beyond use date of 4 hours. Immediate use compounding is a situation where we compound out of immediate urgent need for a patient. This is done in room air using aseptic technique. But you cannot use more than 3 different sterile components. As an example, if you needed a 150 milliequivalent sodium bicarb drip, this would be consisting of 1 bag of sterile water and 3 vials of sodium bicarbonate. This would be considered 2 different sterile components. This slide is for your reference later, showing different beyond use dates for the different categories. Now we'll talk about some more beyond use dating, but we could refer to these as in-use times. And although USP 797 does not use the term in-use times, we could, for all intents and purposes for this discussion, think of it as an in-use time. However, in the real situation and application, we would still apply the term beyond use date to these situations. For an ampule, when opened, it must never, never, never be reused. Once an ampule is opened, it must be used and discarded immediately. A single-dose vial, if opened in an ISO 5 PEC, may receive a 12-hour beyond use date. However, it must be still stored per the manufacturer's direction. So if it must be refrigerated, it must be removed from the PEC and stored back in the refrigerator if it's intended to be reused. For compounded stock solutions, we'll go over that in the next slide. A multi-dose container receives a beyond use date of 28 days unless it's less by the manufacturer's recommendation. A pharmacy bulk container, which is a large container of drug that's used to make multiple doses, such as a 10-gram vancomycin, receives a beyond use date as described in the package insert by the manufacturer, which is usually 4 hours. When talking about compounded stock solutions, let's first discuss what is the intent of a final CSP. A final CSP is intended for one of two situations. One, it's going to be administered, or two, it's going to be used as a component in another CSP, or even repackaged into individual doses. So if it's administered, then USP stops at the point of administration. However, if it's going to be used as a component in another CSP, or even repackaged into individual doses, then it's no longer considered a final CSP, and we must reassign the identity. It now becomes either a single-dose container getting a 12-hour beyond use date, or a multi-dose container if it has preservatives up to 28 days, depending on what your literature states. Let's look at an example for using a compounded unpreserved stock solution. Some people find this a bit complicated, but it's really not that bad. Just think of it as it's really no different than using a manufactured product as a component. The difference is we've just made the product ourselves. So let's say we make an unpreserved stock solution and we're able to give it a beyond use date of 10 days refrigerated. We put it in the refrigerator and 2 days pass, and we need it for something, either to use it as a component in another CSP, or maybe to draw out individual doses for a special patient population such as NICU. So the new beyond use date of the new CSP that we've just made from the stock solution cannot exceed the beyond use date of the original stock solution. So in this example, we had 10 days beyond use date and 2 days passed, leaving 8 days. So our new beyond use date for the new CSP cannot exceed 8 days. Now, if there's anything left in our stock solution, we can go ahead and reuse that, but we need to reassign it a different identity. It now becomes a single dose container, and we can give it a beyond use date of 12 hours as long as we store it appropriately. So in this example, let's say we put it back in the refrigerator and 9 hours pass, leaving 3 hours until we have to discard it, and we need it for something else. Again, to either use as a component in another CSP or to draw out individual doses. We're able to do that, and the new final CSP beyond use date, again, cannot exceed the original beyond use date of the original stock solution, again, which would be 8 days. There are a couple exceptions to this that we really don't see in hospital pharmacy, and that is if we compound something like a pH adjuster that will better stability, or even if we do any terminal sterilization or sterility testing. Now let's talk about actually sterile compounding. Later in this presentation, we'll address negative pressure containment and compounding of hazardous drugs. There are several types of primary engineering controls where we actually compound these sterile preparations. They're known as laminar airflow systems, or LAFSs, restricted access barrier systems, or RABs, also known as glove boxes, and pharmacy isolators. A primary engineering control is also known as a PEC, and this is the hood where you compound. First, we're going to talk about laminar airflow systems, or LAFSs. The laminar airflow system is an open unidirectional HEPA filtered system. There are different types. There are the LAFWs, or the laminar airflow workbenches, and those come in vertical or horizontal airflow. There's an integrated vertical laminar flow zone, or IVLFZ, and there's Class 2 biological safety cabinets, or BSCs, which are primarily used for sterile hazardous drug compounding. There are subcategories, and we'll discuss that a little bit later. First, we'll talk about horizontal laminar airflow workbenches. These are probably the more common type of workbench you'll see in sterile compounding. These LAFWs, these horizontal laminar airflow workbenches, take room air and draw it into a pre-filter that filters out large particles. Then it recirculates the air through the system and pushes it out through HEPA filters located in the back of the PEC that filter out particles of 0.3 microns or larger. The air coming out of these HEPA filters is known as first air. This is the air that you do not want to block. There are also vertical laminar airflow workbenches, and these are pretty much the same concept in that they take air through a pre-filter and filter it back through a HEPA filter, filtering out 0.3 microns or larger, being the first air and the air you don't want to block, but this time the HEPA filters are located in the ceiling and the air is being forced down towards the workbench. There's also what is known as an integrated vertical laminar flow zone, or IVLFZ. These are essentially ISO5 areas serving as a PEC. They're HEPA filters that are placed over some sort of a table or work surface, and there's some sort of physical partition that helps direct and force air downward. Now, these type of rooms are very difficult to obtain and very difficult to maintain. They're not very ideal. There's also Class 2 biological safety cabinets, or BSCs. These are primarily used for sterile hazardous drug compounding, and we'll talk about these a little bit later. But there's a face shield that actually comes down and sits at a precise location where the manufacturer knows that it contains and helps maintain the environment and contains any contamination within that biological safety cabinet. It is vertical airflow where the HEPA filters are forcing air downward to the work surface. Also, there's a negative pressured air drawing into the cabinet and filtered, as well as air being circulated in the cabinet in order not to escape. And these will be externally vented to some extent. And there are different subtypes, and again, we'll look at this later. One important thing to remember about a biological safety cabinet is there is a split. There's an air zone split where the air separates from the front of the cabinet and the back of the cabinet as it forces down to the work surface. The important thing for the compounder to know is not to work in that air split. They need to either work in front of it or in back of it in order to keep their products sterile. Next, we'll talk about restricted access barrier systems, or RABs. These are also known as glove boxes. There are a couple types of RABs that we need to make sure we're aware of. First, there's a CAI, or compounding aseptic isolator. These are for sterile compounding of non-hazardous drugs. Then there's a CACI, or compounding aseptic containment isolator, and these are used for hazardous drug sterile compounding. These are similar to the biological safety cabinet in that they are negative pressure and recirculating air and exhausting that air. But they don't have an open front, and they have these glove ports and an antechamber. Now, if this CAI or CACI, the RABs, the glove box, is in a segregated compounding area, it would be considered Category 1 compounding and receive a beyond use date of 12 hours room temperature or 24 hours under refrigeration. Just like any other PEC, it would have to be in a full compounding room suite to give it beyond use dating of Category 2 or Category 3. Next, we'll talk about a pharmacy isolator. The pharmacy isolator is very unique, and it shouldn't be confused with what we just saw, the RABs or the glove box, even though you'll see glove ports on these. You usually won't see these in hospital pharmacies, but you'll see them more in manufacturer settings or even 503Bs. They're specially closed and contained and actually are self-cleaning. And they're the only PEC that can be placed in a non-ISO 7 buffer room with an anteroom. It can actually be placed in a ISO 8 room and still get Category 2 or Category 3 compounding beyond use states. Our next topic, we're going to talk about garbing, hand hygiene, and cleaning. Cleaning, garbing, and hand hygiene are important to maintaining our microbial control over our environments. People are the main contamination factor for our clean rooms. Skin particles shed at the rate of 1 million particles per hour or more depending on activity, and particles are covered with microbial growth. Garb contains and lessens the spread of these microbes, and cleaning removes these microbes as we continue throughout the compounding day. There are, however, some employees that are at higher risk for contaminating our environments. These are people with rashes, tattoos, oozing sores, conjunctivitis, active respiratory infections, or any other active infection. If a person coming in to work into your clean room has any of these conditions, they must report it to the designated person. The designated person then assesses the situation to see how much of a risk they are to infecting or contaminating the environment or the CSP. If the designated person decides to allow them to work, they must document this and document the reason for why. Certain garb is required for compounding of sterile products. The garb must be low lint and does not have to be sterile for Category 1 and 2, but sterile for Category 3. Surgical masks are commonly used in sterile compounding. These come as an ear loop that holds them in place or they tie in the back, but it's important to understand that these masks need to be worn, folded, formed over the nose, and pulled down under the chin, and also the folds face down. Head and hair covering is a bouffant-style head cap. Surgical caps are no longer permitted. Men with beards need to wear a beard cover, and actually any growth at all should require a beard covering. Shoe covers or dedicated shoes are required. And also the gown. The gown needs to be tight on the wrists and closed around the neck and have no pockets. Gloves need to be sterile, powder-free, and have an IPA or isopropyl alcohol breakthrough time. Garb must be stored away from areas of contamination such as water and changed whenever they're soiled or the integrity is in trouble, like with a tear. And also they need to be disposed of after use. Category 3 compounding, the garb is very special. Not only does it have to be low lint like all the other garb, but it needs to be sterile and cover all skin. No exposed skin is allowed in Category 3 compounded buffer rooms. It's important to refer to your facility's SOPs on hand hygiene and garbing. The facility is responsible for establishing the order of garb and documenting it in the SOPs. The order of garb will be dictated by the location of the sink. The sink can be located inside the anteroom or outside the anteroom. If it's inside the anteroom, it can also be on the dirty side or the clean side. However, when it comes to gloving, there are specific rules that apply. Gloving must occur in an SCA or in a classified area. This classified area should be in the anteroom. It can be in the buffer room, but you want to avoid that in order to decrease potential exposed skin in that buffer room. Now, however, gloving may never happen in an ISO 5 PEC. This slide gives some examples of garbing with respects to the location of the sink, whether or not the sink is in the anteroom on the clean side, in the anteroom on the dirty side, or even outside the anteroom. But before we go there, we have to remember to remove all outer garments, all cosmetics, all hand and wrist jewelry, and any exposed jewelry, including piercings. Nails need to be natural and clean and trimmed. No polishes, gels, or extenders, and eyeglasses, if worn, need to be disinfected. You'll note in each of these scenarios that as the sink moves to the dirtier area, that the frequency of alcohol hand scrub increases at certain points where the hands may become contaminated. It is important to understand and recognize that alcohol hand scrub must be the last step and applied prior to donning gloves. As it pertains to hand hygiene, we need to clean under our fingernails with a nail pick under warm running water. We need to wash our hands with soap and warm water for 30 seconds up to our elbows and rinse from our fingertips down to our elbows. And we also need to use a low-lint disposable towel to dry from fingertips to elbows. When we wash our hands for 30 seconds, we need to ensure that we watch a clock to track that 30 seconds. Remember, no scrub brushes, no electric dryers, and soap dispensers may not be refillable. And also alcohol hand scrub dispensers must be placed at strategic locations. Doffing garb is a very important process and needs to be outlined in your SOPs. And we need to remember that doffing is important because our garb contains microbes and skin particles that we're trying to keep from the environment. So we want to doff in a slow and controlled manner, usually removing garb right side out. We want to slowly roll it into a ball and then slowly discard it inside of a waste receptacle. Remember, when we doff garb, it all must be discarded. We cannot reuse it. The only exception is for the gown. It may be saved for Category 1 and 2 compounding per shift. For Category 3 compounding, the gown may not be reused. But for Category 1 and 2, the gown may be reused per shift, but it needs to be clean and the integrity must be intact with no rips or tears. It should be removed on the clean side of the anteroom and hung on the clean side of the anteroom, or at least in a classified area. All garb must be discarded after it exits the compounding area, or even after cleaning, whether that be daily or monthly cleaning, all garb must be discarded. Donning and doffing should not occur at the same time because we want to keep the person going into the buffer room who is donning as clean as possible. Also, donning and doffing gloves in an ISO 5 PEC is not allowed at all. We do not want any exposed skin in an ISO 5 PEC. When it pertains to a segregated compounding area, doffing should not occur within 1 meter of the PEC. We want to keep our doffing process away from that PEC as much as possible. And if we're using the gown, we want to hang it right side out, either adjacent to or just within the parameter of the segregated compounding area. Now that we've just talked about hand hygiene and garbing, let's go over some training requirements. On this slide, you'll see some minimum requirements that's required every month for people who compound. Not only training, but they have to demonstrate this knowledge and ensure competency. But really what I want to point out here is the aseptic technique and the hand hygiene, garbing, and gloved fingertip testing. For those who compound, this is required not just every 12 months, but instead every 6 months. For Category 1 and 2, and for Category 3 every 3 months. So for Category 1 and 2, every 6 months, if the person does not do the aseptic technique, hand hygiene, garbing, gloved fingertip testing every 6 months, then they are not allowed to compound. So with the designated person or anyone with direct oversight of the IV room, they're only required to do these every 12 months. However, if they're expected to go into the IV room at any given moment and compound, then they cannot unless they are on the rotation of every 6 months. For all other personnel, those who are doing in-process checks or maybe EVS who helps clean the rooms, if they do, then the facility is able to declare what kind of training they need and document it in their SOPs. And just as a reminder, Alabama State Board of Pharmacy does require this or one similar of a CE that's 2 hours for recertification of the Parenteral Pharmacist Recertification for the state. Garbing, glove fingertip testing, and media fill testing occurs with a documented observation. The reason for this is that you can not only fail the process of the task, but also through a documented observation. When it comes to testing for glove, garbing, hand hygiene, the person will proceed with the entire garbing process. They will don sterile gloves and fingertips will be tested, and they will show that they can actually do the process and grow 0 CFU on their fingertips through this entire test without using IPA or isopropyl alcohol. If this is an initial assessment, then the person will have to provide this test 3 consecutive times without growing anything on their fingertips before being able to compound. When it comes to the media fill testing, the person will introduce the items into the hood or the PEC as they would any other compound during compounding sessions, but then again, no IPA will be used after this. They will manipulate the media fill according to the most difficult compounding session for the facility, and again, they will have their fingertips tested as well as the direct compounding area. The fingertips in this scenario, after the aseptic manipulation, can grow 3 CFU but no greater, and that's both hands combined. The surface sample will be acceptable again to grow 3 CFU but nothing greater. When it comes to incubation, the glove fingertip samples and the surface samples will be incubated at 30 to 35 degrees Celsius for no less than 48 hours, and then 20 to 25 degrees Celsius for no less than 5 days. For the media fill, it will be incubated at 20 to 25 degrees Celsius for no less than 7 days, and 30 to 35 Celsius for no less than 7 days. Failure for a media fill test or a media fill bag would be any turbidity whatsoever. Okay, we're going to move forward and we're going to talk about cleaning of controlled environments. And what's important here is to know your process, know your products, and know your dwell times. Before we delve too deeply into cleaning, we want to first talk about some definitions. First, a cleaning agent is an agent that usually contains a surfactant or maybe even an enzymatic product, and it's going to be used to remove dirt, debris, microbes, and residual drugs and chemicals. A disinfectant agent is going to be an EPA-registered disinfectant with a specific dwell time that's going to be used to destroy funguses, viruses, and bacteria. Now, a sporicidal disinfectant is an agent that targets fungal and bacterial spores. A spore is something that some microbes will use to keep itself alive during unfavorable conditions. Once the spore lands on a favorable condition, it breaks open and allows the microbe to flourish. When it comes to isopropyl alcohol 70%, some of us can remember when this was the one-all, be-all cleaning agent for all IV rooms. This is no longer the case. Now it's really looked to more as a residue removal product. It does have great microbial coverage and helps keep our microbial contamination down throughout the compounding day as long as these other products are used as well. So IPA does a great job in helping maintain our environment, but also will remove residues left behind by these cleaning agents. Let's talk about the frequency at which we clean our PECs or our hoods. This chart describes the cleaning frequency of a PEC or a hood. It's important to remember that when we introduce items into a hood, they must be sterile. So only cleaning agents that are sterile can be used, and only cleaning wipers that are sterile can be used in this process. If you're using any kind of a tool to extend your reach to certain areas of the hood, then you're going to have to clean and disinfect that item, followed by IPA prior to use. So when cleaning and disinfecting the entire hood, we're going to do this daily on days when it's used, and also if there's any known or suspected contamination. If you are a 24/7 facility, then it's recommended that you actually do this every shift. For a sporicidal disinfectant, we're going to use that monthly at a minimum for category 1 and 2, and weekly for category 3. For sterile IPA 70%, we're going to use this after cleaning and disinfecting our hoods to remove residues from the cleaning agents. And before initiating compounding, we're going to only clean the work surface. And then also use IPA 70% every 30 minutes during the compounding process. If the compounding process takes longer than 30 minutes, we're not going to interrupt it to clean, but instead we'll finish what we're doing, and then we'll go back and we'll disinfect the work surface with a disinfectant, and then follow it by IPA. The actual technique of cleaning a PEC is not really described in literature, but here are some of the best practices that we can put through. But first, let's remember, never spray into the HEPA filters, because that can ruin the HEPA filters. And it would be best practice to either use a pre-saturated wipe or to pour your cleaning agent onto a wiper. When cleaning a horizontal airflow PEC or hood, we want to remember that, as best practice would dictate, the airflow helps dictate how we're going to actually clean the hood and the order in which it's cleaned. In normal circumstances, a horizontal airflow hood is going to be cleaned from top to bottom, moving from the inside out away from HEPA-filtered air using overlapping strokes. Remember that the cleaning agent and IPA and any other cleaning tools or wipers must be sterile. As an example of cleaning a horizontal airflow PEC or hood, we're going to start in one of the upper corners of the hood of the ceiling and move side to side with overlapping strokes, moving outward from HEPA-filtered air. Next, you're going to clean the back of the hood, remembering that the grate that you're cleaning is actually protecting the HEPA filter behind it, so you don't want to press too hard. But you're going to start in an upper corner, moving side to side and downward with overlapping strokes. After this is done, usually this would be the best time to clean a bar if a bar is present. Next, we'd want to clean the side walls of the hood. Again, starting in one of the sides in the upper hand corner, moving down, moving forward and back up with overlapping strokes and outward. Then you'd repeat that with the other side of the hood using a different wiper. Then finally, you'd clean the work surface by starting in a back corner, moving side to side and forward with overlapping strokes and away from HEPA-filtered air. Next, we'll talk about cleaning a vertical airflow PEC or hood. Remember that the airflow is going to help dictate the way we clean the hood. This is fairly the same to what we just discussed with one small change. But again, we're going to start from top to bottom, moving away from HEPA-filtered air using overlapping strokes. Again, remembering that only sterile cleaning agents and sterile cleaning wipers or anything else used in the hood must be sterile. Option 1 is primarily used in what would be called a biological safety cabinet, but we'll discuss this a little bit later. But again, you'll see that the examples on this slide are the same with the exception of step 3. And again, we'll discuss that when we get to hazardous drugs. But for a hood that's vertical airflow and designed for non-hazardous compounding, sterile compounding, we're going to do the same thing. First, we'll start at the ceiling in the back corner, moving side to side, overlapping strokes and outward, then to the back of the hood, starting in the upper corner, moving side to side downward, overlapping strokes. Then step 3 is what changes. We're going to start with one side of the hood in the upper hand corner and move vertically downward, and then remove the wiper, go back up, overlapping the swipe you just made, and continue this process until you move to the exterior of the hood. And then repeat the other side with the same fashion, but using a different wiper. And then finally, again, cleaning the work surface would be necessary in the back corner, moving side to side and outward with overlapping strokes. Next, we're going to talk about cleaning and disinfecting of secondary engineering controls, or SECs. These are the rooms where we do sterile compounding. We'll start in the same fashion when we talk about cleaning in the upper corners of a cleaner environment and moving down and outward to their dirtier environments. So starting in the buffer room up high, moving downward and outward to the anteroom and beyond is how we're going to be cleaning. So for category 1 and 2 compounding, we're going to clean and disinfect daily on days when it's used. We're going to clean the PEC and the equipment inside the PEC, remembering that only sterile agents and wipers are allowed inside that PEC. In the room itself, we can have non-sterile cleaning agents and non-sterile wipers. We should be using sterile, but we don't have to when it's on the exterior of the PEC, but we should, but we don't have to. It can be a non-sterile item. Now, we're also going to include on our daily cleaning pass-throughs, work areas near the PEC, the sink, the garbing bench, floors, and any other high-touched areas. And this is all going to be documented. So category 1 and 2 for monthly cleaning, we're going to do with a sporicidal, remembering to look at your manufacturer's dwell time for each of these. There will be a disinfectant dwell time, but also a sporicidal disinfectant dwell time. So monthly with the sporicidal for category 1 and 2, we're going to clean our ceilings, then we're going to clean our walls. All daily cleaning will be included in monthly cleaning, and including our shelves, storage bins, equipment outside the PEC, and all other items that are inside that SEC or secondary engineering control of that room. Just a side note for a segregated compounding area, ceilings don't have to be cleaned and disinfected unless they're noticed to be soiled. Now for category 3 compounding, things are a bit more frequent. Daily cleaning is going to occur just as described on days when used, and it's going to include the PEC, as well as pass-throughs, work areas near the PEC, sink, garbing bench, floors, and high-touched areas. But the change here is with weekly cleaning. A sporicidal will be introduced on a weekly occasion for all daily cleaning. And then monthly cleaning for a category 3 compounder is going to be the same as category 1 and 2. It's going to include everything in that room, from the ceilings to the walls, floors, and everything that's inside that room. We really can't move on from talking about cleaning and disinfection without talking about removing residues from surfaces in our classified environments. This is very important because all cleaning agents we use in our IV room actually leaves residues behind. Once residue builds up, it becomes sticky and helps trap microbes, which is a contamination issue in itself. So it's really important to remember to remove residues. This is going to be done at different frequencies depending on your facility and the type of cleaning agents they use. Now, sterile IPA 70% is excellent at removing residues. And in the room on a daily scale, you're using isopropyl alcohol 70% all the time, so it's basically removing residues on a daily basis. But however, when you get to the floors, this is where it really lacks, because we're really only doing the floors once a day and never cleaning them any other time. So that residue builds up, so it becomes very important to remember to remove those residues on those floors. The ceilings and walls as well need to be watched, but a little bit less frequently because those are only done once a month. So with the removal residue process, yes, you can use IPA on the floor, but it's not always recommended and probably shouldn't be used all the time because it could damage the floors depending on what type of floor we have. One of the best ways to remove residues on floors is to first use sterile water for injection or irrigation and wipe it dry, and then follow with an application of your disinfectant to finalize your cleaning. When it comes to introduction of components into your controlled environment, it's an extremely important topic because we are only going to be as clean as things being put into that room. This chart describes the USP minimum standards for introduction of components into your rooms from an unclassified area or even between classified areas, and compares it to what we would consider the best practice and the reasoning why for the difference. So first, what USP says on how to introduce a component from an unclassified area to a classified area, such as the anteroom, it says you must use a sporicidal disinfectant or an EPA registered disinfectant or sterile IPA. But actually what we should be doing is always using that sporicidal disinfectant because anything and everything can be on these items. They can be covered with molds and funguses and spores. They're stored in cardboard boxes. They come from refrigerators or even totes that are dirty. So everything and anything can be on these, and we want to keep that stuff from getting into our room and contaminating it. Now, in a perfect situation, once it's wiped down with the disinfectant, and if it's ready to be used and compounded with, the compounder can take it, wipe it down with sterile IPA 70%, and introduce it into the hood. But what usually happens is the item is going to sit in your anteroom during staging processes and such for some kind of unspecified unspecified amount of time. If that occurs, the item should be wiped down with something. And I would suggest either IPA or a disinfectant or a sporicidal. Any of those would be sufficient. But then always, 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 prior to that item being introduced into the PEC or the hood, it must then be again wiped down with sterile IPA, 70%. Documentation is extremely important for what we do. We're an open book, and if it's not documented, it hasn't been done. Cleaning will be documented per shift or per day, depending on your facility and how it determines it in your SOPs. Some facilities will have a weekly cleaning. These will be specifically Category 3 compounders, but additionally other compounders may decide, Category 1 and 2, may decide on a separate weekly cleaning as well. And then, of course, all categories is going to have a monthly cleaning that's going to be documented. Pressures at a minimum will be documented once per day, with positive pressures being a minimum of 0.020 water column relative to the surrounding area in a cascading fashion, meaning that the buffer room will be a positive 0.020 greater than the anteroom, which will be a positive 0.020 greater than the general pharmacy. A negative pressure area will be a negative 0.010 to a negative 0.030 water column relative to the adjacent area. Note that we are keeping these out to 3 decimal points in order to avoid rounding into compliance. Temperatures will be documented once per day, and remember the temperature is going to be adjusted to the comfort of the employee. It does help reduce microbial growth, but really we're looking for that comfort of the employee, because an uncomfortable compounder makes errors and also sweats, increasing microbial growth in the air. The suggestion is to be 20 degrees Celsius or cooler. These will be better described in your SOPs. But remember, drug storage must be taken into consideration if you are storing drugs in your classified area. Humidity is going to be documented once per day, and it's going to be adjusted to the comfort of the personnel as we just described, and it should be a 60% or drier. Now, again, if you get it too low, we're working against potential for electrical malfunctions. Refrigerators and freezers will also be recorded once per day. In addition to documenting our environmental conditions, we're also going to document our compounding with master formulation records and compounding records. A master formulation record is a record of how to compound a certain item. The requirements for a master formulation record is on this slide, and we're not going to discuss it in this presentation, but just to know that a master formulation record exists for compounding an item and is required for compounding for more than one patient. That would be for batches, and also if a non-sterile ingredient or component is being used. Compounding records exist also and are records of the process of compounding with recording of lot numbers, etc. And again, lists here on this slide the requirements for a compounding record, which we won't discuss in this presentation. But just know that compounding records exist and are required for all compounding, all Category 1, 2, and 3 compounding, whether or not you're using sterile or non-sterile components. All compounding must have a compounding record. Also, if compounding for immediate use, if the compounding is for more than one patient, then a compounding record must exist as well. For documentation purposes, a prescription label or prescription itself or a compound can exist as a compounding record, and even IV workflow systems can be also used as compounding records, as long as it's all readily available. Environmental sampling is done to see if contamination is present at unacceptable levels, and also to assess if our processes are being followed and adequate to keep our compounding environment safe for sterile compounding. Environmental sampling takes place by sampling air and surfaces. This slide outlines the proper air and surface sampling specifics, talking about frequency, location, timing, and equipment used. For air sampling, the frequency will be done every 6 months for Category 1 and 2 compounding, and every 30 days for Category 3. Locations to be sampled are going to be in the interior or inside the ISO 5 PEC or hood, and also in your ISO 7 and ISO 8 rooms, targeting the high traffic areas. The time to sample air is going to be under dynamic conditions when most people are present that represents your normal compounding scenario. And for equipment used, you're going to see this something called an air impaction device being used in auger plates. And we'll probably talk about that here soon, but normally most people are going to have their certifier do this, but the pharmacy itself can take this on themselves as well. As for surface sampling, we're going to do category 1 and 2, we'll do this monthly. And for category 3, they're going to do this every week, in addition to the DCA or the direct compounding area in their hood will be sampled after each batch. The location for surface sampling is going to be done on the interior of the PEC or the hood, the equipment inside the PEC, the staging areas around the PEC, because this is very important. This is the next point of introduction into the hood, and through pass-throughs. Pass-throughs, when they're so small and contained, if anything gets in there and becomes contaminated, then that object will contaminate your rest of your area. And also, you're going to look at frequently touched areas or surfaces. It's going to take observation. We're going to look for areas not only where things are placed and picked up from, but also where there's physical touch. Now, the time of sampling for surfaces is going to be at the end of the compounding activity or end of a compounding shift or day, and prior to cleaning and disinfecting. What we're going to use for this is going to be auger plates or paddles or swabs, and it's going to have a convex or raised auger with a neutralizing agent in it in order to neutralize cleaning agent residues left behind on the surface to get a true and accurate sample. Also, air and surface sampling is going to be done in other scenarios, such as new builds, after servicing, new equipment introduced into the environment, after construction or repairs, and after any kind of identifiable problems, such as sterility testing failures, and also after trending excursions, whether they be from fingertips or surfaces or media fills. Now note, it's really important to understand and recognize that air and surface sampling must have a map. This map is going to identify the areas you're sampling so any investigator can look and make sure that you are actually testing the appropriate places. For the types of auger used during air and surface sampling, we're really looking at the same types of auger. But we're going to focus on what's called TSA auger because it supports both bacteria and fungus. We can use other types of auger like MEA and SDA because they support fungus, but we would have to include a TSA auger as well because we're looking for both bacteria and fungal growth. So it's just really easy to just use TSA. But remember, important thing to remember here is when we're talking about surface sampling, we need to have the raised and convex auger in order to have complete total touch to the surface. Also, making sure that we have a neutralizing agent inside that auger to neutralize cleaning agents left behind on surfaces so we can get a true and accurate sample. Another very important thing to remember is when we purchase these augers, we need to have a certificate of analysis on file for each lot number in order to prove that the auger actually does grow. Once we've conducted air and surface sampling, it now comes time to incubate and identify our samples. When it comes to incubation of samples, we really have 3 different ways we can incubate. But we're really going to focus on what I listed here as the primary way, or the one using TSA. Just note, there are 2 alternative ways you can do sampling that require 2 different plates per one surface area. But really, we're going to focus on the primary way because it's probably a little bit more efficacious. But just note that the other 2 do exist. You can come back to this slide and look at it yourself if you'd like to study up on it. But for the primary way we incubate, again, remember we're going to invert these samples to avoid condensation, first of all, and incubate them. And we're going to first incubate the TSA auger at 30 to 35 degrees Celsius for no less than 48 hours. We're going to stop and document our CFU from that first incubation period. Then we're going to transfer it to a second incubator and incubated at 20 to 25 degrees Celsius for no less than 5 days. Then we're going to stop and document our total CFU growth. Now, it's really important to remember that even though we're incubating at 20 to 25 degrees Celsius, and that is pretty much room temperature, we still have to incubate this in an incubator for control purposes. Once we have incubated and we've counted our CFU, or colony-forming units, we're going to then look at what we have and analyze our results and see if we need to take action. The chart here in the top of the slide shows you what each ISO classification requires and what is the actionable limit. So for an ISO 5 area, air can only grow greater than, or can only grow 1 CFU. Anything greater would be an actionable level. For surfaces of ISO 5, anything greater than 3 would be actionable. So 3 would be allowed, but actionable would be greater than 3. And then so forth and so on for ISO 7 and ISO 8. Now, what's important to understand as well is we don't have to identify to the genus level anymore. We used to have to, even if we had 1 growth. Now we don't have to do this unless we grow our actionable levels above our actionable levels. Then we'll have to identify to the genus level. And also those highly pathogenic organisms that we used to be worried about, again, those are no longer a concern. We're just looking for CFU growth, and if we exceed those levels, then we need to identify to the genus level, and then we allow our identification to drive our investigation. Now we're going to transition to handling of hazardous drugs and the sterile compounding of those hazardous drugs. Remember that USP 800 is going to be used in combination with USP 797 for manipulating hazardous drugs that are sterile. Now, one thing to mention is that USP 800 is about handling of hazardous drugs. It's not just about compounding. It does follow the drug all the way through your facility from receipt all the way through waste. We want to make sure that's understood, but we are going to talk today about hazardous drug compounding that is sterile. Now, not all hazardous drugs possess the same risk. So what USP 800 allows us to do is to use something called a risk assessment. So here's a key clarifying statement located in box 1 of USP 800. It says that the only drugs that have to follow USP 800 all of the time are going to be any hazardous drug APIs. Those are going to be active pharmaceutical ingredients. These are going to be concentrated powders and liquids used to compound drugs into a dosable form, or any antineoplastic drug requiring manipulation on table 1 of NIOSH. Note there's 3 factors here. It has to be an antineoplastic that's requiring manipulation and appears on NIOSH table 1. Pretty much all other drugs can be assessed out of USP 800 as long as we can put in some other process in place to allow us to keep our employees safe. So if an assessment of risk is not chosen to be done on drugs, then yes, every single drug that's hazardous must follow USP 800 100%. But again, only USP 800 says that the only drugs that have to follow are the hazardous drug APIs and the antineoplastic drug requiring manipulation on table 1 of NIOSH. Employing assessment of risk is like the game of baseball, where you have the catcher and the umpire behind home plate. This is where all the actions happen. This is where most of the problems could occur, where people could get hurt. So these are like your hazardous drug APIs and your antineoplastics on table 1 require manipulation. These people will have to have full garb on all the time. Then you have your infield. There's still a lot of action going on and potential harm, but it's a little more controlled. So these people can be held to a different standard as long as we have processes in place, and they don't have to have so much garb maybe. Then you have those in the outfield, where really maybe the risk is almost zero. And pretty much maybe the risk only happens if you're not paying attention at all. So again, these people can be assessed out to a different standard. But it's worth mentioning again that USP 800 allows this assessment of risk, but the only drugs that cannot be released from USP 800 are the hazardous drug APIs, or active pharmaceutical ingredients, and an antineoplastic drug on table 1 of NIOSH requiring manipulation, other than repackaging and counting. But again, if an assessment of risk is chosen not to be employed, then yes, everything has to be handled per USP 800. It's sort of like the game of football now, where everything and everyone on the field is at equal risk because we don't know where the problem is going to occur. We don't know who's going to get hit. We don't know who's going to get hurt. So everyone has to be garbed up the same and be prepared for anything. So now we're going to introduce a couple other terms to our cleaning list, which is called deactivation and decontamination. So just as we discussed in non-hazardous drug compounding, we're going to go over some definitions and include the two new ones, deactivation and decontamination. Deactivation is the rendering of a substance inert or inactive, and it's done with an EPA-registered oxidizer, peroxide, or some other chemical. And then we have decontamination. Decontamination is the removal of hazardous drug residues, and that can be done with water or alcohol, peroxide, or something else, as long as it's removing those residues. Now, not every chemical out there has a known deactivator. So if you can deactivate, that would be the way to go, but if it doesn't have a known deactivator, you're going to really focus on decontamination, removal of those hazardous drug residues. Then remember cleaning. Cleaning is very similar to decontamination in that it removes something, but it's going to remove dirt, debris, microbes, residual chemicals, and drugs. And it's going to have a surfactant. And then as a review, disinfection is destruction of organisms with an EPA-registered disinfectant. And sporicidal disinfection is going to be destruction of those bacterial and fungal spores. And just to note, there are those one-step processes or one-step products out there that actually can do all of this. You actually have products that are deactivators and decontaminators and can be used in cleaning and disinfection, as well as being sporicidal. So very important to remember that because it makes your job so much easier. It makes things streamlined. And then just as a brief review, isopropyl alcohol, 70%, is really used to reduce microbial growth through sanitization because it doesn't kill everything, but also to remove residues from chemicals left behind that we're just talking about. When it comes to compounding of sterile hazardous drugs, we're going to look at the special requirements for protective equipment or PPE that we need to have in place to keep our employees safe. PPE used for sterile compounding of hazardous drugs has to be disposable. We cannot reuse it at all. Now, there are some things that are reusable, like goggles or full-face respirators with battery packs. If we have those in use, then yes, we do have to deactivate them and decontaminate them prior to reuse, but otherwise, PPE must be disposable. Also, PPE should never be worn outside of a negative pressure containment room. It needs to be considered as contaminated with trace contamination and disposed of in that trace contamination waste bin in the negative pressure room. There's some more specifics we'll discuss here shortly, but in general, this is the rule of thumb. And then if you have any contaminated clothing with a hazardous drug, you must never take it home. It would be destroyed there at the facility, or it would be washed per the facility's policy and procedures for hazardous drug contamination. And remember that USP 800 deals with not just compounding, but everything: receipt, storage, transport, compounding, administration, deactivation, cleaning, spills, and wasting. And proper PPE must be employed for every one of these steps. You can refer to NIOSH for general guidances of different types of scenarios and use this along with USP 800 to make a robust program. Now we're going to take a little bit deeper look at each item of PPE used for compounding of sterile hazardous drugs and talk about the specifics of each of those. Gloves used during compounding of hazardous drugs must be ASTM rated by the American Society for Testing Materials. 2 pairs of gloves must be used for compounding any hazardous drug. One pair of glove will go under the cuff of the gown and the other one will go over the cuff. The outer pair of glove must be sterile. Now you can have non-sterile gloves underneath, but it's not the best practice. You really need both of those pairs of gloves to be sterile. The gloves must be powder-free and inspected for holes for integrity. Also, we need to know our breakthrough times for the chemicals we're handling in our facility to make sure the gloves can withstand that chemical for what amount of time, and including our sterile IPA. Also, we're going to change our gloves every 30 minutes or per the manufacturer recommendation, and always, always, always wash your hands after removing the gloves. Now, not only are 2 pairs of gloves required for compounding, but also for administration of an injectable anti-neoplastic drug on table 1 of NIOSH. Gowns or frocks are going to be disposable and made of a polyethylene-coated polypropylene or other laminate. They're going to close in the back so there's no opening in the front where drugs can get through in case there's a splash. There's going to be no seams, so nothing can soak through holes. And they're going to be long-sleeved and have elastic cuffs. There really needs to be a permeability study on your gowns from the manufacturer for the hazardous drugs handled in your facility. You're going to change these gowns per the manufacturer, but if there's no permeability study, then you're going to change it every 2 to 3 hours. And again, you should never wear these outside of a hazardous drug negative pressure area. More on that a little bit later. For head, hair, and shoe covering, pretty much we're going to be using the same items used in non-hazardous drug compounding. However, you can get a more robust type of PPE with laminate that is going to provide better protection that's just not required. But again, for hair and head protection, we're going to cover with a bouffant style cap. That's going to help with not only microbial spread, but also contamination of hazardous drugs being caught in the hair and spread amongst the facility and the person. You know, of course, men with beards are going to have to wear a facial beard cover. Shoe covering is going to be, again, the same as we use for compounding of non-hazardous drugs, but you can find a better laminate to offer better protection. But in this scenario, when we are compounding with hazardous drugs, we're going to wear 2 pairs of shoe covers. We're going to don these before we go into the CSEC, or the Containment Secondary Engineering Control, or the negative pressure room, and the outer pair will be doffed in that room prior to exiting. Then there's something called sleeve covers. These are not a requirement, but again, can be used for added protection. And again, remember, for Category 1 and 2, these don't have to be sterile, but for Category 3, they would have to be sterile. And again, these will have to be disposable, and they can be worn for extra protection. And again, they're going to be a polyethylene-coated polypropylene or other laminate. Eye and face protection must be used if there is a risk of spill or splash. If compounding inside a negative pressure room and inside of a biological safety cabinet, then eye and face protection is not necessary since you have a barrier between you and the compound. However, if you are compounding outside the CPEC or the Containment Primary Engineering Control for whatever reason, then yes, you must wear eye and face protection. Other times of this would be requiring if for administration, spills, and even cleaning. Now, goggles provide occlusive eye protection and is what needs to be used. What would be unacceptable for use is just eyeglasses because spills and splashes could get around it. Goggles with a full mask offer a full range of splash protection. For respiratory protection, here we see a surgical mask. This would not be appropriate for handling hazardous drugs or compounding of hazardous drugs. Surgical masks could be worn in negative pressure room when using a biological safety cabinet because, again, you have that protective barrier between you and the compound. But in general, handling hazardous drugs in a simple surgical mask is inappropriate for handling of hazardous drugs. The appropriate mask would be an N95 respiratory mask. This offers a physical barrier against splashes and sprays and particles that are suspended in the air. However, we must remember this offers no protection from gases. It's sufficient for airborne particles to filter those out so they don't get into your respiratory system, but for gases we would need another mask. All employees will have to be fitted for this type of mask. For respiratory protection against gases, we're going to use something like this. This is an elastomeric half mask with multi-gas P100 filter. The P100 filter is more of a catch-all filter for an unknown situation. If you have a known situation, you can actually switch out this filter to be a more specific filter for the situation. But again, for those unknown situations, this P100 filter should be used. Now note that this half mask does not provide eye protection. And also, this mask would be a requirement for unpacking hazardous drugs that are not sealed in a plastic container or if there's breakage found within your delivery. This type of mask would even be more appropriate in scenarios for unknown situations, especially if there's splash risk involved. This is a full-face piece chemical cartridge respirator. Again, same situation as a half mask, it offers eye and full-face protection. All the respiratory protection we just mentioned must be fit tested. However, this one, the powered air purifying respirator or PAPR, does not have to be fit tested and would be a more appropriate choice for different types of scenarios or people who can't be fit tested or even men with facial hair. These are simply hoods or helmets that are attached to a hose with a battery pack that supplies fresh air to the person wearing the outfit. For spills larger that can be contained by a spill kit, or for known or suspected airborne contamination through powder or vapors suspended in the air, or when deactivating, decontaminating, and cleaning underneath the work surface of a CPEC, or Containment Primary Engineering Control or Biological Safety Cabinet, these types of masks must be considered or should be considered. Either the full face piece cartridge respirator or the powered air purifying respirator or PAPR. I want to draw special attention to cleaning underneath the work surface of the CPEC. When this is done, you lose your containment because you have to get underneath it and you will be raising the protective barrier, which is going to disrupt airflow and expose the employee to unknown hazards in that hood. So you must wear or should really strongly consider these types of masks. Closed system transfer devices, or CSTDs, are used to prevent contamination of the employee as well as the environment. There are many different types of devices out there on the market, and the choice needs to be based on the NIOSH definition of a CSTD, and also ensuring that there are independent peer-reviewed articles to be read and to back the claims of the CSTD. Basically, the NIOSH definition of the CSTD is a device that will help prevent hazardous drug contamination getting outside the unit, as well as preventing microbial contamination getting within. A CSTD cannot be used in place of a biological safety cabinet. Also, when compounding, a CSTD is not required, but we really should consider using it because it does help decrease contamination within that CPEC and will then therefore help stop the spread of contamination. And also, it's going to help protect the person administering the product because when it comes to administration of an anti-neoplastic drug on Table 1 of NIOSH, a CSTD is required. We want to give the person administering the drug all the pieces necessary to be successful. Also, we want to ensure that a CSTD is compatible with the hazardous drug we're using, since many hazardous drugs can be corrosive in nature. I'll let you come back and review this chart at a later date if desired. It basically shows the USP 800 mandated PPE for different types of manipulations. And also note it shows when 2 pairs of gloves or 2 pairs of shoe covers are required for those manipulations. Containment Secondary Engineering Controls, or CSECs, are negative pressure rooms where compounding of hazardous drugs take place. Note there is no longer any exception for low-volume hazardous drug compounding. All hazardous drug compounding must occur in a negative pressure room. This is an example of a containment segregated compounding area, or CSCA. It's an unclassified room that's going to be externally vented to the exterior of the facility, both the room and the CPEC, or the biological safety cabinet. It's going to be away from other areas of activity, and it's going to be negative pressure of a negative 0.010 to a negative 0.030 water column. Note again, we're going out to 3 decimal points in order to avoid rounding into compliance. There will be at least 12 air changes per hour or more, and this type of room is going to be limiting our beyond use dating to category 1, as 12 hours room temperature and 24 hours under refrigeration. A sink can be located either outside of this room or inside the room, but if inside the room, it needs to be at least 1 meter away from the CPEC. This is an example of a Containment Secondary Engineering Controller CSEC in a compounding room suite. HEPA-filtered air will be supplying clean air to the ISO 7 negative pressure buffer room. This negative pressure buffer room will be connected to a positive pressure anteroom. The negative pressure buffer room must be between negative 0.010 and negative 0.030 water column. The anteroom will be a positive pressure of a positive 0.020 water column. The negative pressure buffer room must be externally vented to the exterior of the facility, as well as the CPEC, or the biological safety cabinet, must also be externally vented to the exterior of the facility. 30 air changes per hour is required in that negative pressure buffer room. The anteroom must also have a minimum of 30 air changes per hour. In this type of scenario, in a compounding room suite, you can get the category 2 or 3 compounding beyond use dates established in USP 797. This is an example of a negative pressure storage area where certain drugs like hazardous drug APIs and antineoplastic on Table 1 of NIOSH require manipulation must be stored per USP 800. Again, remember, all other hazardous drugs can be assessed out by an assessment of risk, so you need to be ensured that you have that assessment of risk for storage for other drugs. For those hazardous drug APIs and antineoplastics on Table 1 of NIOSH require manipulation, storage areas such as a buffer room, negative pressure buffer room, is acceptable. But you want to be aware that if you are a high-volume compounder of hazardous drugs, or if you do non-sterile hazardous drug compounding, you may want to consider one of these rooms. It is fixed walls with negative pressure of a negative 0.010 to a negative 0.030 water column with at least 12 air changes per hour or more, and the room is externally vented to the exterior of the facility. We want to emphasize some information on storage of hazardous drugs. Those hazardous drug APIs and antineoplastic drugs on Table 1 of NIOSH require manipulation are required to be stored separately from other inventory in a negative pressure room with at least 12 air changes per hour that's externally vented to the exterior of the facility. Non-antineoplastics and reproductive risk hazardous drugs, as long as there's an assessment of risk in place, may be stored with other inventory as long as the policy permits. Non-sterile and sterile hazardous drugs are permitted to be stored together, but consideration should be made for those non-sterile ingredients or drugs. They should not be stored in a sterile compounding area due to potential contamination of that area. Refrigerated antineoplastics require a dedicated refrigerator in a negative pressure area. It is acceptable and permissible by USP 800 to have a refrigerator dedicated in the negative pressure room and have it positioned near an air exhaust. Next, we're going to look at the containment primary engineering controls for compounding hazardous sterile drugs. These are biological safety cabinets and restricted access barrier systems, or RABs. There are several different types of biological safety cabinets, and Appendix 3 of USP 800 does a good job of describing these different types, as well as giving information on what might be more appropriate for your compounding environment. This is an example of a Class 2 biological safety cabinet, and there are subtypes of these types of cabinets. The subtypes are an A2 with 70% recirculated air, B1 with 30% recirculated air, and B2 with 0% recirculated air. There's a face shield that goes down to a safe area that's noted on the front of the biological safety cabinet where an alarm will sound if it's unsafe to use. It's going to be vertical airflow with negative pressure and externally vented to the exterior of the facility. For a restricted access barrier system, we're want to look at the CACI, or the Compounding Aseptic Containment Isolator. Note there is a CAI that is not appropriate for hazardous drug compounding. Instead, we need to make sure it's a CACI. These are negative pressure using recirculating or total exhaust, and if in a CSEA, a segregated compounding area, this would be considered Category 1 compounding with 12 hours at room temperature and 24 hours under refrigeration beyond use dating. This RABS system would have to be in a full compounding room suite with a buffer room and an anteroom in order to get longer USP 797 beyond use dating. We have to remember that there are important processes we put into place in order to reduce contamination during compounding. After compounding a sterile hazardous drug, we want to clean up appropriately in order to mitigate any kind of potential contamination getting outside of our CPEC into the external environment. First, we're going to deactivate and decontaminate the final CSP container, and then we'll remove our outer pair of gloves and discard those inside the CPEC into a sealable bag that's been set aside for waste. Then we'll deactivate and decontaminate the final CSP a second time and remove the CSP from the biological safety cabinet or the CPEC and place it in a sealable hazardous drug containment bag for delivery. It's important to understand the special processes for doffing PPE used for compounding of hazardous drugs in order to mitigate potential contamination to your environment. First and foremost, the outer pair of gloves used after compounding must be doffed inside the CPEC into a sealable waste bag. Also, although not necessarily needed or required to be used, if using sleeve covers, then those must also be doffed inside the CPEC into that same sealable waste bag. When it comes to shoe covers, the outer pair of shoe covers must be doffed in negative pressure. All other garb may be doffed into the anteroom, but really we should consider doffing all garb used for sterile compounding of hazardous drugs inside that negative pressure room. However, doing so would require 2 pairs of garb at all times, so when the outer pair is doffed, the person is not exposed without any garb. Washing hands, of course, is a necessity after doffing all garb after compounding of hazardous drugs. SOPs must reflect our processes and the way we doff in order to ensure employees understand the proper doffing process. Deactivation, decontamination, and cleaning, disinfection of the CPEC is important to understand as well. Deactivation, decontamination, cleaning, and disinfection of the CPEC occurs at regular intervals just like it would for non-hazardous drug sterile compounding. We also have to remember that only sterile cleaning agents and sterile cleaning wipers are allowed inside the CPEC. And again, if there's any special tools needed to reach difficult locations, those would have to be deactivated, decontaminated, cleaned, and disinfected prior to use. Decontamination of the CPEC must occur daily when in use, when compounding in between different hazardous drugs, after spills, before and after certification, and prior to any scheduled airflow disruptions. We also want to deactivate, decontaminate, and clean and disinfect the work tray underneath the work tray if it exists. That's going to be done minimally at a monthly basis. When we do so, we want to ensure the entire CPEC is deactivated, decontaminated, and cleaned prior to and after the work tray is removed and replaced. Also, respiratory protection is needed to be strongly considered in order to keep the employee safe. And then, of course, after using all these agents, we need to repeat by applying sterile IPA 70% to remove residues. When deactivating, decontaminating, cleaning, disinfecting our negative pressure rooms themselves, we're going to follow the same process as described earlier in the presentation for non-hazardous drug compounding. And it's going to follow a daily and a monthly schedule for Category 1 and 2, as well as the special weekly edition in Category 3. We're going to use, again, something to deactivate, something to decontaminate, something to clean, and something to disinfect the walls, the ceilings, everything in the room, reminding us that there are very efficient and effective one-step products out there that we can use to help streamline our cleaning process. One thing to remember, very important, we need a designated mop for the hazardous drug room that cannot exit that room. Appropriate garb needs to be used for cleaning of hazardous drug areas to protect our employees. Garb needs to be chosen that's resistant to cleaning agents used, and 2 pairs of ASTM-rated chemo gloves need to be worn, 1 pair going under the cuff of the gown, 1 pair going over the cuff. An impermeable gown that's disposable needs to be used, and eye protection and face shields should be worn when there's a splashing risk. Respiratory protection needs to be taken into consideration per the manufacturer as they require, keeping in mind that in order not to overcompensate for our employees and put them at burden, we need to remember that often agents used to clean requires ventilation, and we should take that into consideration that we do have air changes per hour in our room, which offers extra ventilation. There are certain work practices that can be put into place when handling hazardous drugs that will help mitigate potential contamination of the environment and to the employee. But first, let's remember that a signed consent of understanding of the risks of handling hazardous drugs needs to be on file for everyone of reproductive age that is handling hazardous drugs. When receiving hazardous drugs, there's some things to take into consideration. Anti-neoplastics and hazardous drug APIs must be received in either neutral or negative pressure. They cannot be received in a positive pressure area. Other receipt of hazardous drugs beyond hazardous drug APIs and anti-neoplastics can be dictated by the SOPs, but there should be always a dedicated space to receive these deliveries. There should always be a visual examination of delivery and checking for damage or leakage, and the supplier should be containing any hazardous drug delivery in an impervious bag. If not, consider working with your supplier and try to get them to adhere to those regulations. 1 pair of ASTM-rated chemo gloves are required for receiving hazardous drugs, and other garb is required if it's damaged. And also, we want to place all hazardous drugs into storage immediately and not let them sit around. If something is received damaged, then the container needs to be sealed and returned to the supplier. If the supplier rejects the return, then the facility must dispose of this as hazardous waste. If for some reason there's something inside the damaged container that's needed, then the container can be sealed up in plastic and transported to the CPEC. Items can be removed and decontaminated inside the CPEC, and then the damaged materials can be resealed up and removed, making sure everything is deactivated, decontaminated, and cleaned and disinfected inside the CPEC prior to removal, and then, of course, the CPEC must also be deactivated, decontaminated, cleaned, and disinfected. When receiving products from a manufacturer, we need to ensure we deactivate, decontaminate prior to storage. This is because we know that contamination exists on the exterior of the package at the manufacturer level. The picture in the red on the right is a photo of an anti-neoplastic with notable contamination. Often, contamination can't be seen, but it's still there. Also, we need to take into consideration of our compounded preparations that are hazardous. We need to ensure that we seal them in a hazardous drug containment bag, use ASTM chemo-rated gloves during delivery, and always have a spill kit on hand in case of an accident. The picture on the right in the yellow is a picture of betadine injected into a PVC bag. We can see after studying it on paper for hours, the paper turns black, showing that chemicals can get through the PVC. USP 800 tells us that employees who handle hazardous drugs need to be trained on how to handle a spill. Spill kits need to be readily available and be tailor-made to the facility as they need. Spill kits need to be prominently available in compounding areas, receiving areas, and other areas where hazardous drugs are handled. Signs need to be available to restrict the area in case there is a spill, and spills must be documented. Exposed employees need to be evaluated for health issues, and spills larger than can be cleaned up by a spill kit require a PAPR or a full-face mask respirator with chemical cartridge. This concludes the live didactic portion of the Alabama State Board of Pharmacy Parenteral Recertification CE. To ensure compliance, make sure someone at your facility documents the return demonstration of your aseptic technique. Also, credit for the CE requires a passing score of 80% on the examination that will be emailed to you.